You're taught from literally day one of looking at cardiac monitors that the P wave comes before the QRS. Like, first the top of the heart squeezes, then the bottom squeezes.
Right. It's the absolute golden rule of telemetry.
Exactly. So what does it mean when the P wave suddenly appears after the QRS? Or when it just vanishes entirely?
I mean, it breaks your brain a little bit the first time you see it. You're staring at the grid paper, looking for that familiar top-to-bottom sequence, and the heart is just doing something completely backward.
Backward is the perfect word. And that is exactly what today's deep dive is all about. This one is custom built for you, the telemetry techs, nurses, monitor technicians out there running the central stations. We're moving way beyond just memorizing flashcards of squiggly lines.
Oh, yeah. We need to really dissect the physiology of retrograde P waves. Because to understand what happens when atrial activation throws it in reverse, we really have to look at the normal electrical commute first.
Right, which starts high up in the right atrium at the SA node.
Yeah.
That's your primary pacemaker.
Exactly. It fires, and the electrical wave just washes down through the atrial tissue, hits the AV node, travels down the His-Purkinje system, and finally triggers the ventricles to contract.
I always picture it like a drop of water hitting the top of a pond, just rippling smoothly downward.
That's a great visual.
And because that electrical wave moves from the top right to the bottom left of the heart, it heads straight toward lead 2.
Yeah, let's visualize where that camera is actually sitting.
Mm-hmm.
Lead 2 is essentially a camera positioned on the patient's left hip, looking up toward their right shoulder.
Okay.
So when the SA node fires, the electrical current is moving directly toward that camera lens. And in electrophysiology, anytime current moves toward a positive electrode, the pen on the EKG machine goes up.
It paints a positive deflection.
Exactly. That gives you your nice, smooth, upright P wave. It's like traffic traveling smoothly down a one-way road.
But retrograde conduction completely flips the script. The impulse isn't starting at the top anymore. It's starting somewhere near the middle or the bottom of the heart, usually around the AV junction, and traveling superiorly. So
Yep.
Bottom to top.
Right. It's the wrong way driver, the rogue car that gets on the off-ramp and just starts driving the wrong way up the street.
Man, that is terrifying, both in traffic and on a monitor.
Very true. The depolarization vector shifts entirely. Normally, we are in a frontal plane axis pointing down and to the left. But with a retrograde signal, the electricity is physically moving away from the bottom of the heart up into what we call the northwest quadrant. That's -90 degrees to -150 degrees.
Which means our telemetry cameras are going to catch it running away.
Right. Your inferior leads, so leads 2, 3, and AVF, they're all sitting down at the bottom of the heart. Since the retrograde electrical wave is moving directly away from them, the pen drops below the baseline.
So you get an inverted negative P wave.
Yes. And conversely, lead AVR is sitting way up on the right shoulder. The retrograde wave is rushing right at it, so lead AVR will show a completely upright P wave.
Okay, so the morphology, like the shape and direction of the wave, tells us the signal is moving backward. But the tricky part isn't just the shape, is it?
No.
It's the timing. A retrograde P wave might happen just a split second before the QRS, or right after it, or it might just disappear into the QRS complex altogether.
I want to focus on that disappearing act because it trips up so many people. The P wave isn't actually gone.
Wait, let me stop you there and unpack this, though. If I am looking at a 6-second strip, and there is just no P wave anywhere, how can you definitively tell me there is still atrial activity happening? It feels like we're just making an educated guess at that point.
It's not a guess. It's actually just a matter of electrical mass. Think about the sheer size difference between the muscle walls.
Right.
The atria are thin-walled receiving chambers. The ventricles are thick, massive pumping chambers. So when the ventricles depolarize, they generate a massive amount of electricity.
They yank the pen on the EKG paper really hard.
Exactly. The surface EKG is just a summation of all the electrical activity happening at that exact millisecond. If the thin atria and the massive ventricles are depolarizing at the exact same time, the tiny electrical signal of the atria is just entirely swallowed by the towering QRS complex.
Oh, wow.
Yeah, the atria are experiencing an action potential. The muscle cells are chemically firing. You just can't see it on the skin surface because the ventricular voltage just overwhelms the sensor.
So as a clinician watching the screen, you have to ask yourself a sequence of questions. Where is the P wave? Is it positive or negative in the inferior leads? Is it before, inside, or after the QRS? And most importantly, is that relationship consistent from beat to beat?
Consistency is your biggest clue. If the retrograde P wave is locked into the exact same position relative to the QRS every single time,
Yeah.
you are looking at a driven circuit.
Right.
Which brings up the fundamental issue. If the SA node is asleep or failing, who hijacked the car?
In most of these retrograde cases, it's the AV junction, right?
Yeah. The AV node is fascinating. Every cardiac cell has a property called automaticity, which is the innate desire to fire off its own electrical impulse.
Like they all want to be the boss.
Exactly. But the SA node is the fastest, firing at 60 to 100 times a minute. It suppresses all the other cells. It's like the conductor of an orchestra dictating the tempo. But if the SA node fails or, gets blocked by scar tissue, the AV junction realizes no signals are coming down.
So it wakes up and takes over as the backup pacemaker.
Exactly.
Here's where it gets really interesting to me, though. The AV node isn't designed to be a pacemaker. Physiologically, it's a toll booth. Its main job is to catch the SA node signal, hold onto it for a fraction of a second, and then release it to the ventricles. It delays the signal so the ventricles have time to fill with blood before they squeeze.
That's the beauty of it. The toll booth suddenly has to become the engine. And because the AV junction sits right in the middle of the heart when it fires its own impulse, that electricity doesn't just go one way.
It shoots downward toward the ventricles and simultaneously shoots backward toward the atria.
It's a race in two opposite directions.
That explains the timing variations.
Yeah.
If the backward signal travels up to the atria slightly faster than the downward signal reaches the ventricles, you get an inverting P wave just before the QRS.
Right.
If they tie the race, they fire at the exact same time, and the P wave is hidden inside the QRS. And if the downward signal wins, the ventricles fire first, and the retrograde P wave shows up after the QRS.
You're visualizing the exact cellular mechanism. That's perfect. But let's add a layer of complexity here. Say you're at the central station, and you see an inverted P wave just before the QRS. How do you know if it's a junctional rhythm or just a rogue ectopic cell firing from the very bottom of the right atrium?
Oh, because both would travel backward and create an inverted P wave in lead 2.
Right. Both are going bottom to top.
That is a really subtle difference. Ectopic atrial versus junctional? What's the differentiator?
It's the PR interval. You have to measure the time it takes from the start of the P wave to the start of the QRS. If it's a low ectopic atrial rhythm, the impulse starts in the atrial tissue. Even though it's moving backward, it still has to physically pass through the AV node to get down to the ventricles.
Meaning it still hits the toll booth.
Yes. It gets subjected to the normal AV node delay, which relies on slow-moving calcium channels rather than fast sodium channels. And because of that delay, the PR interval will be normal, so 120 milliseconds or greater.
Okay, got it.
But in a junctional rhythm, the impulse originates inside the AV node or the junctional tissue right below it. It bypasses that proximal delay entirely. So, a junctional rhythm with a preceding retrograde P wave will have a very short PR interval, less than 120 milliseconds.
That is an incredible tool for the monitor tech. You just measure the PR interval and the mechanism literally reveals itself.
Yeah, it's all right there on the grid.
And we should definitely touch on the speeds, because the junction has different gears. A standard junctional escape rhythm, that passive protective backup, keeping the patient alive, that runs at 40 to 60 beats per minute.
Right.
If the junction gets irritated by ischemia or maybe digoxin toxicity, it can speed up to an accelerated junctional rhythm at 60 to 100 beats per minute. And over 100, it's junctional tachycardia.
But here's a trap I see all the time. Rate alone should never be used to define the rhythm.
Really? Never?
Never. A rate of 70 beats per minute does not automatically mean normal sinus rhythm. If the rate is 70, but the P waves are inverted with a short PR interval, you are looking at an accelerated junctional rhythm. You must interrogate the morphology, not just read the number on the top corner of the screen.
Okay, let's shift gears from those slower backup rhythms to the really fast stuff. What happens when that retrograde traffic gets caught in a high-speed loop? Like the classic supraventricular tachycardias, AVNRT and AVRT.
AV nodal reentrant tachycardia, or AVNRT. This is where retrograde P waves become vital diagnostic clues. Inside the AV node of someone with AVNRT, there are basically two distinct electrical pathways. We call them the slow pathway and the fast pathway.
Let me try to break this down with an analogy, because the refractory periods are what make the loop possible, right? It's like a high-speed roundabout with a fast lane, the alpha lane, and a slow lane, the beta lane.
Yes, the refractory period is the time it takes for a pathway to recharge after firing, like a camera flash needing a moment before it can flash again.
Right.
The fast pathway conducts electricity very quickly, but it has a long refractory period. It takes a long time to recharge. The slow pathway conducts electricity slowly, but it recharges almost instantly.
So normally, a sinus beat comes down, hits both pathways, but races down the fast pathway and triggers the ventricles. The slow pathway signal gets there late and just fizzles out because the muscle is already fired.
Right. But AVNRT gets triggered by a premature atrial contraction, a PIC. An early beat comes down from the atria. It hits the AV node, but the fast pathway is still refractory. Its camera flash hasn't recharged yet from the previous beat. It's blocked.
Okay, so the electrical impulse is forced to travel down the slow lane.
Exactly.
And because it's moving slowly, by the time it finally reaches the bottom of the AV node and triggers the ventricles, that fast lane has had enough time to fully recharge.
You've got it. The impulse hits the bottom, triggers the ventricles, and simultaneously turns around, jumps into the newly recovered fast pathway, and shoots backward up to the atria. It creates a continuous blazing fast electrical loop. Down the slow, up the fast, over and over. Like this is typical slow-fast AVNRT.
Wow. And because the signal is rushing up the fast pathway to the atria, at almost the exact same microsecond it's triggering the ventricles, the retrograde P wave is going to be buried, right?
Yeah. Almost completely. It's either hidden inside the QRS or it happens just a few milliseconds after the QRS finishes. And this is where the expert monitor techs really earn their money without turning the shift into an EP masterclass.
What are they looking for?
When that retrograde P wave distorts the very end of the QRS complex, it creates what we call a pseudo R prime wave in lead V1.
Pseudo meaning fake.
Yeah.
It looks like a tiny extra upward spike at the end of the QRS, almost imitating an incomplete right bundle branch block.
Yes. And in the inferior leads, you might see a pseudo S wave, which is a tiny downward spike at the tail end of the QRS. These aren't ventricular waves. They are the retrograde P wave peeking out from behind the massive QRS voltage.
Contrast that with atypical AVNRT or AVRT, where there's an actual physical extra accessory pathway outside the AV node, like in Wolff-Parkinson-White.
Right. In those circuits, the physical distance the electrical loop has to travel is much longer. Because the circuit is larger, the time between ventricular depolarization and retrograde atrial depolarization is extended. So the retrograde P wave is clearly visible much later, falling solidly after the QRS. We call that a long RP tachycardia.
This highlights something massive. A narrow, complex tachycardia that appears to have missing P waves doesn't mean the atria aren't firing. It just means they're firing simultaneously with the ventricles.
Precisely.
But, why does any of this matter to the patient? If I'm watching the central monitor, identifying a pseudo R prime is intellectually satisfying, sure, but how does this backward electrical activity actually affect the human being lying in the hospital bed?
We have to translate the squiggly lines into hemodynamics. A normal top-to-bottom atrial contraction provides what we call the atrial kick. It pushes the final 20 to 30% of blood volume down into the ventricles right before they contract.
It stretches the ventricular muscle so it can snap back with maximum force.
Yes. But in a junctional rhythm or an AVNRT loop, the atria and ventricles are depolarizing simultaneously, which means they're contracting simultaneously.
Oh, man.
The atria are trying to push blood down into the ventricles, but the ventricles are already squeezing. As soon as the ventricles squeeze, the mitral and tricuspid valves snap violently shut to prevent backflow.
So the atria are literally squeezing against closed steel doors.
Exactly. The atrial kick is gone. Cardiac output instantly drops. But the consequences of that trapped blood are even more severe. Fluid doesn't compress. Since it can't go forward, it shoots backward.
Right.
On the right side of the heart, the right atrium squeezes against the closed tricuspid valve, sending a high-pressure retrograde wave of blood straight up into the jugular veins.
Those are cannon A waves. So what does this all mean for you, the listener? It means when you call the nurse about this rhythm, the patient might be feeling dizzy or short of breath, not just because their heart rate is off, but because their heart's plumbing is literally fighting against itself. You can physically see the patient's neck veins bulging and pulsing violently with every single heartbeat.
It's wild to see. And the left side of the heart is even more vulnerable. The left atrium squeezes against the closed mitral valve, shooting blood backward into the pulmonary veins. Remember, there are no valves protecting the lungs from the heart.
So that backward pressure surge goes straight into the pulmonary capillary beds.
Yes, it physically forces fluid out of the vessels and into the lung alveoli. You get sudden, unexplained dyspnea or even flash pulmonary edema. a patient can go into acute respiratory distress.
Wow.
And the clinical trap is this can happen even if the patient has completely preserved left ventricular function. Their main pumping chamber is totally fine. It's an electrical timing issue that has turned the atria into high-pressure backflow pumps.
Okay, we've covered the cellular refractory periods, the vectors, and the physical plumbing collapse. Let's build a real-world scenario. You're sitting at the telemetry station. Bed 4's heart rate jumps from 70 to 160 beats per minute. How do you actually process that strip without just panicking and yelling for the nurse? Let's go through the systematic 10-step method.
You don't just look at it, you interrogate it systematically. Step 1, determine the ventricular rate. Is it 50 or is it 160?
Right. Then step 2, check the regularity. Reentrant tachycardias and junctional rhythms are usually metronome regular.
Step 3, examine the QRS width. A narrow QRS confirms the impulse is traveling down the normal His-Purkinje highway, even if it originated in the AV junction.
Step 4 is where you stop glancing and start hunting. Search carefully for atrial activity. And step 5 goes right with it. Look immediately before and immediately after every single QRS complex.
Step 6 is the secret weapon. Compare the morphology. Pull up the patient's baseline rhythm. Compare the current strip to their normal sinus P waves from 4 hours ago. Is there a new bump at the end of the QRS that wasn't there before? Is the P wave now inverted and led to where it used to be upright?
Then step 7, check for consistency. Is that new bump locked into the exact same distance from the R wave on every beat?
Step 8. Use the rate and the P wave location to consider the mechanism. Is it a slow junctional escape or a fast reentrant loop?
Step 9. Correlate with the clinical picture. Like, did they just get a dose of medication? Does it match previous telemetry?
And finally, step 10, escalate the rhythm change according to your facility's protocols. I want to focus on why step 8, identifying the mechanism, is so critical, rather than just using the generic SVT label. Calling a narrow fast rhythm SVT is like telling a mechanic your vehicle is broken. It doesn't tell them if the engine is flooded or the battery is red.
So let me push back on that a bit, though. It's so tempting to just see a fast, narrow rhythm, slap the SVT label on it, and move on to the next monitor. But you're saying that shortcut is a major pitfall. If I'm the monitor tech, my job is to alert the team that the patient is in a rapid, dangerous rhythm. The doctor's going to order the meds anyway. Does it really matter if I specifically identify a pseudo or prime wave?
It matters immensely because your telemetry interpretation often guides the very first medication they reach for. If you ignore a change in P-wave morphology compared to the patient's baseline, you miss a crucial diagnostic clue. If you identify typical AV-NRT with a buried retrograde P-wave, the doctor knows the circuit is entirely contained within the AV node.
Okay.
Pushing adenosine, which temporarily blocks the AV node, will break that specific circuit and cure the tachycardia.
But if I measure a long RP interval and spot the retrograde P wave far away from the QRS,
then the mechanism might not be AV node dependent. It could be an atrial tachycardia. If the team pushes adenosine for an atrial tachycardia, it will block the AV node, the ventricles will pause, and you'll just see the underlying rapid atrial flitter waves marching through. It doesn't fix the arrhythmia.
you just subjected the patient to the feeling of impending doom that adenosine causes without therapeutic benefit. By doing the detective work, you are literally changing the medical management from, say, amiodarone to adenosine.
Exactly.
That makes perfect sense. Let's cover a few other common mistakes to avoid. The first one is obvious, assuming P waves must come first. That bias blinds you to the retrograde ones. Second is brushing off inverted P waves as just artifact without investigating.
Artifact doesn't march out perfectly with the QRS complex. If it's consistent, it's physiological. Another major pitfall is missing a P wave hidden inside the QRS, or mistaking a retrograde P wave that falls after the QRS for a peaked or strangely shaped T wave. You have to hunt for the notch.
And as we mentioned earlier, never identify a rhythm based purely on heart rate. And don't fall into the narrow complex equals SVT trap without actually scrutinizing the baseline for atrial activity.
Right. To summarize it, retrograde P waves are the EKG's way of screaming that the normal top-down SA node pathway is bypassed.
Yeah.
Whether it's a slow junctional backup rhythm trying to save a failing heart, or a blazing fast reentrant loop spinning out of control inside the AV node, the relationship and the direction of the P wave unlocks the mystery.
It's all about moving your eyes past the giant, distracting QRS complex and interrogating the quiet moments on the baseline.
Before we wrap up, I want to leave you with one final, really fascinating concept from the research regarding retrograde rhythms. We spent a lot of time talking about how the loss of the atrial kick and the contraction against closed valves damages hemodynamics. What happens when the clinical team successfully cardioverts the patient?
The rhythm breaks, the SA node takes over, and you see beautiful, upright, normal sinus P waves on the monitor. The electrical crisis is over.
The electrical crisis is over, yes, but the patient might still be incredibly symptomatic. There is a physiological phenomenon known as atrial stunning. Even after normal electrical pacing returns to the monitor, the physical muscle tissue of the atria can remain paralyzed.
Wait, really? So the EKG shows perfectly timed electrical P waves, but the muscle itself isn't squeezing?
Precisely. The prolonged fibrillation or retrograde high-pressure pumping leaves the atrial myocytes mechanically stunned. It can take up to a full month for the physical mechanical atrial pick to fully recover.
Oh, wow.
Yeah, the electrical recovery on your screen does not equal immediate mechanical recovery in the patient's chest. They may still have low cardiac output and experience shortness of breath for weeks while the muscle heals.
That is wild. The electricity is back online, but the plumbing is still bruised. It completely challenges you to remember that a post-cardioversion strip, just because the jagged white lines look perfect again, doesn't mean the patient is fully stabilized. Thank you for walking through the deep mechanics of this with us.
My pleasure.
For everyone listening at the central station or the bedside, keep an eagle eye on those inferior leads. Measure your PR intervals, and remember, finding the QRS is only half the job. Until next time, keep interrogating the baseline.